So I'm going to talk about some couple case studies using the Pentacam and also how Pentacam can help replace some of the equipment in your diagnostic and OR suite. I am a consultant for OCULUS. Traditionally, we didn't really have great preoperative measurements to predict true corneal power. You have the posterior corneal astigmatism that contributes to corneal power and astigmatism. I've been a big pioneer of an advocate of intra-operative aberrometry, which was sort of my go-to method to predict corneal power. And so that adds a fair amount of time to an operating case and sort of the expensive environment of the operating room. And so if you can help use a device that can help predict what you might find in the operating room by using intraoperative aberrometry, if you can replace that, or maybe just give yourself more confidence in that, that's a huge step forward, I think, in cataract surgery. Also, it's interesting, who in the room does laser or femtosecond LRIs? Anybody use, yeah, so if you're gonna do a femtosecond LRI for astigmatism, you're doing that before you get into the operating room. So, I've been a big fan of intraoperative aberrometry to predict or to measure corneal astigmatism, but the problem is that's after you're already in the OR, and if you're doing a laser LRI, you need to know that information before you're getting into the OR. So it'd be nice to have a tool that can predict that true corneal power. So I'm going to go through a couple case studies that shows how I'm using the Pentacam AXL and how it correlates to intraoperative aberrometry. This is the first case is a 74-year-old male with history of cataracts and astigmatism. You can see the manifest refraction showed about 1.75 diopters of astigmatism. Often that can be an indication of how much astigmatism is going to be measured. Sometimes you might be thinking this patient might use, let's say, a T4 toric lens based on the manifest refraction. As the two previous speakers discussed, the sphere power is very accurate with the axial length. Traditionally I was using IOL Master 500 and then, excuse me, 700. And now, and I was traditionally doing that plus topography on all my cases. So it's sort of two measurements. Now I can do one measurement and make my clinic a little bit more efficient. And basically with this one measurement, we're getting a great predictor of sphere power. So this, the Pentacam shows you what the sphere power will be with a number of different predictive measurements. Also, it's showing you this true corneal refractive power. In this case, it's predicting that the true refractive power is 0.8, a little bit more than the anterior case is just 0.7, but on the true cornea is 0.8, predicting that a T3 lens will leave this patient with about 0.24 diopters of astigmatism with the rule. A lot of times if it's against the rule of astigmatism, I like to kind of overcorrect that a little bit and leave the patient with just a bit of with the rule of astigmatism. So in this case, I said, okay, with the Pentacam prediction, I'm going to use a T3. What's also nice is the Holladay report goes through a number of different refractive maps. You have the axial map on the top left. As far as below that, you have the tangential map that shows a little bit more of the potential irregularity. Maybe this patient has a little bit of surface disease. The second or the middle two graphs show the corneal thickness and then the relative corneal thickness. And it's nice, as you'd expect, the thinnest part is in the center of the cornea, so it's a pretty regular cornea. You don't see any outliers in the relative corneal thickness. And then you have an elevation of the front and back. Again, let's say if this case you're thinking about doing a limbo relaxing incision driven by femtosecond laser, you can feel confident that you can use that tool, that you don't have pathology that you're incising into. If you're just going off of IOL Master, you really wouldn't have a sense of what is this a normal cornea and how will it respond to that incision. This is another great report. This is a normal eye. I think we may see some more abnormal eyes, but the Holladay EKR, or equivalent K reading report, and you can see this distribution, the blue sort of graph there that's showing what is the corneal equivalent corneal reading and how tight is that. In an abnormal eye, you see the wide distribution, sort of a multifocal cornea. You can see this is a pretty tight reading with a pretty regular amount of total corneal power. What's also nice is you get not only, it takes into account the front part of the cornea and the back part, so you get the true corneal power, not only for sphere, but also for astigmatism. In this eye, it was predicting 0.8, which was guiding that T3. In the OR, we used intraoperative aberrometry, and this intraoperative aberrometry correlated almost exactly to what we found with a predictive Pentacam. It showed 0.87 against the rule, and again, it also showed that a T3 would be the correct lens to kind of lead this patient a little bit with the rule. So just basically confirms what we're seeing in the OR preoperatively. So if you can sort of streamline the intraoperative step, or maybe even bypass that step, intraoperative aberrometry can be a little challenging. There's surgical variables that can vary. If you have a small corneal abrasion or something going on in the OR, it can interfere with that reading. So if you can have that information before you walk in the OR, I think that's preferable. This is another case, again, a patient with cataracts and astigmatism with about 2.5 diopters of refractive astigmatism, looking to have basically astigmatism correction with cataract surgery. Again, we get a great range of spherical power predictions. It also has the Barrett calculator, which is great, and the Olsen as well. Again, this true corneal refractive power is predicting 1.6 diopters of astigmatism, as opposed to if you just looked at the anterior case, it'd be 1.3. Maybe at this case, you might say, well, maybe I'll just put a T3 lens in. I think that might be the correct choice, but if you look at the total corneal power, it's predicting a T4 lens. I think the toric lens patients, I think that's sort of the easy refractive surgery that we refractive cataract surgery that we do in our practice. In general, it's, if you can nail those, it gives you confidence. And once you have confidence in achieving the results, I think it gives you confidence to discuss it with more patients. We saw that once we had better measuring tools, our conversion rates went up in our practice because we were more confident in discussing refractive cataract surgery with our patients. So again, this shows it was 1.6 diopters against the rule. You can also look at the maps, see if there's anything irregular before you do this planning, assuring yourself that they'll be a good candidate for a toric lens. Again, the EKR also shows a relatively tight grouping of the corneal power, so you feel confident that you're getting accurate readings. And again, this patient with the intraoperative aberrometry shows that almost measuring, again, exactly what we predicted preoperatively. Intraoperatively, it measured 1.5 as opposed to 1.6. So again, this also confirmed the T4 reading to predict the correct amount of power to correct for that astigmatism. So in conclusion, I think the Pentacam preoperative measurements can predict proper astigmatism correction. Pentacam can be used to confirm intraoperative measurements, but potentially Pentacam can replace those intraoperative measurements, allowing you to be more efficient in the operating room. Thank you.